Welcome to today's webinar, Racial Disparities in Maternal Mortality. It's with a focus on California and a spotlight on cardiovascular disease. For those of you who have just joined, please note that everyone is muted upon entry to the webinar. Please use the Q&A feature in Zoom to ask questions, and they will be addressed at the end of everyone's talks today. And yes, the webinar will be recorded and archived for people who are unable to attend now. So here we go. We are having a little bit of technical difficulties in terms of getting our California Department of Public Health colleagues on the line. While we wait for them to get on the line, let me just briefly introduce to you our speakers for today. First of all, we have, and hopefully we'll get, Paula Krakowiak, from the California Department of Public Health in the Epidemiology Division of the Maternal Child Adolescent Health Unit. And she will provide an overview of the racial disparities that were found in the California Pregnancy Associated Mortality Review, or CA-PAMR, particularly those cases that were determined to be pregnancy related. Then we will hear from Dr. Lucy Van Otterloo, who will speak about the quality improvement opportunities that we were able to obtain from that maternal mortality review. And finally, we'll hear from Dr. Afshan Hameed, who will talk about the CVD screening algorithm that is in the toolkit and how we can move toward equitable implementation of this algorithm in order to identify women with cardiovascular disease in pregnancy. Both Lucy and Afshan were members and reviewers of the California Pregnancy Associated Mortality Review, and we're very delighted to have all three of our speakers here today. We are still waiting for the CDPH people. Okay, well, here we go. Here they are. I'm going to go back to the top. And I'm going to introduce you now to Dr. Connie Mitchell, who's the Deputy Director of the Center for Family Health and has a long and supportive relationship with the California Associated Pregnancy Review. Dr. Mitchell, if you can mute your computer or your audio there when you talk now, you should be able to be heard by the audience. Can you speak up and closer to the phone?
Hold on just 1 second.
Okay.
One phone. Can you hear me now?
Yes, we can hear you now. Oh, just got disconnected. I do apologize for this technical difficulty. Sometimes we think technology will make our life easier, and then other times it just adds additional wrinkles. So I thank you for your patience. I believe Dr. Mitchell will call me back very shortly. Hopefully, I see some chatting that some people have an echo. As the chat says, if you're hearing an echo, it may be that your computer mic is on, and that's what your telephone is picking up right now. Okay. I guess we're not going to hear from Dr. Mitchell at this time. But I do want to say that Dr. Mitchell has been a long supporter of the California Maternal Mortality Project and wanted to point out and why we're here today, in part because there are persistent and troubling disparities in maternal mortality by race and ethnicity in California over quite a long period of time. So while we've been very encouraged to see maternal mortality reduce in California, we are not yet in a place where we have solved all the problems. We need to address this disparity between African American women and all other women. Dr. Mitchell also wanted to present this slide on the disparities that can be seen in infant mortality in California as well. So again, we're seeing a persistent disparity between outcomes between African American, the red line, Hispanic infants, the green line, and white infants, which is the purple line. And in addition to those disparities, we're also seeing disparities in preterm singleton births. So we have a lot of work to do still in California, and we hope that by focusing on cardiovascular disease today, we'll be able to show you how we can do that. Okay. No. All right. It looks like our CDPH friends are still having technical difficulties. I'm sorry for that. Overall, the CDPH strategies for interventions to reduce racial disparities in health outcomes include a wide variety of approaches to address all the multifaceted contributors to those disparities, which includes reducing socioeconomic inequalities, increasing access to health care, ensuring high quality care for all, changing the structural environment in which people live to be health promoting, and to reduce health risks that are borne more by certain subpopulations. We've already introduced our wonderful speakers for today. I'm going to present Dr. Krakowiak's slides, sorry about that, giving you an overview of racial disparities in California from the PAMR data. It's really important to start out by really defining what we're talking about, because there are different ways to measure maternal mortality, and it's important to know what rate we're talking about when we see a graph like I've been showing you. So the graphs, the first rate I want to talk about is the maternal mortality rate, and this includes women who die while pregnant or within 42 days post-pregnancy from pregnancy-related causes. The pregnancy-associated deaths, which are the deaths of women while they're pregnant or within 1 year post-pregnancy, are used in the California Pregnancy-Associated Mortality Review. That rate is also used by CDC and ACOG, because extending that time frame beyond 42 days to a year allows for identification of deaths that are due to pregnancy, such as cardiovascular disease, that can be addressed. The maternal mortality rate, however, is used for international comparisons and allows countries to be compared to one another. We look at two different kinds of deaths among the pregnancy-associated deaths. The first is the pregnancy-related deaths, and those are the deaths that we will be talking about today. These only include those deaths that are related to the pregnancy or aggravated by the pregnancy or its management. There's another subset of deaths that California is very interested in looking at, but was not part of the original PAMR project, and that is those that are not pregnancy related. So this is the subset of pregnancy-associated deaths, things like automobile accidents or other kinds of accidents or deaths due to medical issues that were not related to pregnancy. We have really good news to share in California. You can see from this graph that for many years, California and the US rates of maternal mortality, this is the 42-day rate, were very much in parallel and along the same very much in parallel. But in 2008, the lines diverged dramatically, with California dropping down now to just 7.3 maternal deaths per 100,000 live births, and the United States going upward at 22. However, while we have good news in California for those early deaths, remember the maternal mortality rate was within 42 days. When we look at deaths out to 1 year postpartum, this green line here on this graph, we see a fairly steady rate. So we really want to now start to look at the factors that are contributing to those late deaths. Dr. Mitchell showed this slide, and we see it again. The disparities are ongoing and persistent, and a troubling development and concern that we need to address. So what is California PAMR? PAMR, we call it the Pregnancy Associated Mortality Review. This is a project headed up by the California Department of Health, started in 2006 to enhance the surveillance of pregnancy-associated deaths. And this is done by looking at a variety of data in order to capture all the women who died while pregnant or within 1 year of the end of the pregnancy. The PAMR project overall sought to identify the cause of death and the timing of death, whether a woman's death was pregnancy related. The committee also identified contributing and critical factors that may have led to the death. And most importantly, are the deaths preventable and at what level? And what are the opportunities to improve the care and support of expectant moms? The primary goal overall is to reduce pregnancy-related deaths and their associated health disparities. The team that works on this project in California comes from 3 different agencies: the California Department of Health, the Public Health Institute, and the California Maternal Quality Care Collaborative. And we could not have done this work without the Multidisciplinary Expert Review Committee, among whom was 2 of our speakers today, Dr. Van Otterloo and Dr. Hameed. The methodology is pretty in depth here. This chart shows that first, the death cohort is constructed by bringing together the data sources involved, the maternal death certificates, the birth certificates, etc. Then our team pre-screens the pregnancy-associated deaths. So we aim to look for deaths that are likely to be pregnancy-related. The data is then abstracted and put into a form for all the committee members to review. The committee reviews the cases, identifies these important findings, and then that data becomes analyzed and contributes to the recommendations that come out of our work. This report was issued in spring of this year. It is the culmination of that entire project that I just related to you, and you can find more information about our work and the tools and reports from this review on the CDPH website. We identified over 300 pregnancy-related deaths in the 6 years of the PAMR project. You can see by this chart that we had a lot of deaths to look at, but in the end, the pregnancy-related deaths accounted for 333. The leading causes of pregnancy-related deaths in California were cardiovascular disease, comprising 26% of all the pregnancy-related deaths. You can see the other contributors to pregnancy-related death in California on this chart: preeclampsia, eclampsia at 16%, obstetric hemorrhage 10%, venous thromboembolism 9%, and sepsis 8%. And overall, the pregnancy-related mortality rate was 2.6 deaths per 100,000 live births. When we look at these pregnancy-related deaths by race and ethnicity, we again see that stark disparity, with Black women having a rate of 40 compared to the lower rates of the other race ethnicities. This is a almost 5 times higher rate than white women. And again, when we look here just at the deaths due to cardiovascular disease, we see an even worse disparity. Black women in California have a 7.6 times higher rate of CVD, pregnancy-related death, than do white women. The top contributing factors for cardiovascular disease, pregnancy-related deaths in California included patient level, provider level, and system level factors. Here we show you the patient level factors involved women with underlying medical conditions that either they were unaware of or that was not brought to the attention of the care providers. Delay in seeking care, and this was closely related to lack of recognition of symptoms of cardiovascular disease, which you'll hear more about in the next presentation. Obesity was also a top contributing factor for this cause of death. Among the provider level factors, we saw inadequate response to clinical warning signs that might have led to further testing for cardiovascular disease in women. Even if the disease was identified, there was often ineffective care. In some cases, CVD was misdiagnosed, and there was a failure to refer or to consult with cardiologists or intensivists. We looked very closely at this data to identify what might be different about the Black women who died of cardiovascular disease and the white women and women of other race ethnicities. We were not able to find any differences in these contributing factors by race ethnicity, except for obesity, and that Black women were more likely to have high BMI than others, but there was no differences in preventability by race ethnicity. So we also collected data from that PAMR review that we call quality improvement. And so when we evaluate those quality improvement opportunities, as you'll hear in the next talk, those lead to strategies to help California improve care and reduce morbidity and mortality. Those strategies have resulted in the toolkits that California has produced. I like to say they're California's gift to the country because they are free and available. And when these toolkits are implemented, we can then evaluate that implementation and see whether or not that implementation has had a positive effect. I'd like to turn now the webinar over to Dr. Lucy Van Otterloo, who will talk about the analysis of the quality improvement opportunity data from the maternal mortality review. Lucy?
Thank you very much, Christine, for this opportunity to talk about this work that we've completed. Now that we kind of know why we're looking at cardiovascular disease, I get to highlight how we went about looking at the specific quality improvement opportunities within the PAMR data. As noted previously, of the 333 pregnancy-related deaths, cardiovascular disease in pregnancy accounted for 26%, or 87 deaths, which was the highest among all the causes of death. Despite the high risk of the status that women who died of cardiovascular disease had, 80%, or 70 of these deaths were judged potentially preventable. 26% of the cases were determined to have a good to strong chance to alter the outcomes, and 56% had at least one or some chance to alter outcome if specific actions had been implemented. So we set out to analyze these specific quality improvement opportunities that were determined by the committee to have potentially affected this outcome. A multidisciplinary team of nursing, sociology, and obstetric experts coded and analyzed the quality improvement opportunities using the 4R framework that I'll address in the next couple of slides. The goal being to identify key quality improvement opportunities identified during the review. 276 quality improvement opportunities were identified from the 87 cases of maternal mortality from cardiovascular disease, and this was the most of the QiO, the quality improvement opportunities for the cause of death. Next slide. Oh, one back. In addition to determining cause of death, contributing factors, and the chance to alter outcome, the California PAMR committee also reviewed each case for quality improvement opportunities. I'll call them QiOs because that's too long of a thing to keep saying. We basically answered the question, in this particular case, what alternative approaches to recognition, diagnosis, treatment, or follow-up at the system, provider, and/or patient level may have led to better patient care and or better outcomes. While contributing factors help us to determine causes, in contrast, the QiOs represent both actual and ideal actions or policies that are recommended or desirable, but many may not be possible in every single circumstance. These consensus-generated opportunities for improvement reflect lessons learned that we would possibly help others avoid similar maternal deaths in the future. For each case reviewed, the committee identified one or more QiOs that could be implemented to improve care and services in California. Next slide. So the framework that guided the qualitative analysis of QiOs utilized the 4 domains that were previously described by Bingham, Linden, LaGrue, and Main, and utilized by the National Partnership for Maternal Safety consensus bundles that many of you have seen or are utilizing. The domains of readiness, recognition, response, and reporting characterize actions that are necessary to prevent maternal mortality and morbidity and can guide implementation of quality improvement measures. The 4th domain, reporting, pertains to actions that are taken by individual facilities for their own case review to identify events from a systems perspective or compliance with their own standard protocols and guidelines. Since our data didn't actually include any of this kind of information that's relevant to reporting, it was not included actually in any of these analyses. Next slide. So we independently assigned each of the 276 QiO items as in readiness, recognition, or response. When a QiO statement referenced multiple domains, it was assigned to more than one, like readiness and recognition. As you can see from this slide, these domains don't exist alone. They are intertwined, they overlap each other, and one can affect the other, and one fixed in one area could fall and cascade into the others as well. Initially, we identified these definitions, what we meant by readiness, recognition, and response, and ongoing coding decisions were discussed among all of the researchers. After individually coding the QiO, the team met and reviewed each code assignment and worked out any discordances through consensus. From there, we developed common themes related to readiness, recognition, and response that you can see here, and I'll talk a little bit more in the next slide. So from the QiOs identified under the readiness domain, 3 major themes emerged that reflect the need for risk assessment and the development of a plan of care for pregnant women with cardiac disease, or who develop cardiac disease in pregnancy or postpartum. The most prevalent theme within the readiness category was the lack of appropriate maternal level of care, meaning that women were cared for in a facility or a department within a facility that was not equipped to handle the severity of the pregnant woman's condition. Inadequate equipment, no specialist available for consultation, led to delays in getting the right diagnosis and the right physician to the bedside. It also impaired the ability to engage a multidisciplinary team for the complex care that is required for women who have cardiovascular disease. In some cases, transfer of the women, especially those with multiple risk factors, to a higher level of facility would have been beneficial. In addition to level of care issues, location of care within the facility was identified as a source of several quality improvement opportunities. Performing procedures on women with high-risk conditions in suboptimal settings, like the cath lab, or not transferring the woman quickly to labor and delivery or the intensive care unit from the emergency department may have contributed to the death or led to delays in necessary medication, resuscitation, and even cesarean section. In addition, several concerns were noted by the reviewers about the apparent lack of standardized policies and procedures in obstetric triage, or ED, to facilitate that evaluation. The second thing to emerge from the readiness domain was the clinician's preparedness to care for the pregnant women with CVD. Considering routine assessment of oxygen saturation when pregnant women have respiratory complaints, especially with known risk factors, and taking into account peripartum cardiomyopathy as a differential diagnosis in the presence of ongoing shortness of breath and anxiety were determined to be improvement opportunities. Improving knowledge on how to perform cardiopulmonary resuscitation on a pregnant woman may also have improved outcomes. We felt that although these seemed to be more of a response issue, it was also an important educational clinical opportunity. The final theme in the readiness domain centered on the lack of awareness on the part of the woman regarding the seriousness of her signs and symptoms and when to seek treatment. In many cases, women appear to ignore or minimize warning signs of dyspnea, orthopnea, and chest pain. Some women had symptoms for several weeks before they finally sought care. So education for women was seen as being important. Education was also appeared to be needed on the importance of preconception care to address issues of weight loss or weight gain, treatment program options for substance abuse, and effective birth control in women with known severe cardiac disease to avoid pregnancy altogether. Next slide. From the QiOs identified under the recognition domain, 3 main themes were also identified: missed risk factors, missed signs and symptoms, and misdiagnosis evaluation. Recognition of high risk factors for cardiac disease was noted among several QiOs within this domain. The most frequently overlooked risk factor included family or medical history, such as childhood heart disease, previous cardiac surgery, Marfan syndrome, chronic or new onset hypertension, especially in African American women, obesity, and current or past substance use, especially methamphetamines. The apparent failure to obtain or incorporate these risk factors into the differential diagnosis often led to missed opportunities for appropriate evaluation and workup. The most common QiO concerned missed clinical warning signs. Maternity clinicians did not seem to recognize the symptoms of cardiac disease or associate these symptoms with possible cardiac disease. Most of the common symptoms were misinterpreted as respiratory in nature. In fact, the most frequently noted missed symptom was shortness of breath, with or without other additional signs and symptoms, including decreased oxygen saturation, tachycardia, crackles, wheezing, and shoulder pain. Additional signs and symptoms that went unrecognized as indicators of potential CVD were elevated blood pressure, clumping, cyanosis, anemia, heart murmurs, low platelets, fatigue, and edema. Unrecognized hypertension was also identified in several of the QiOs. Although lack of recognition of the signs and symptoms of cardiac disease occurred in all areas of care, including antepartum and intrapartum, it also frequently occurred in the postpartum period, either before discharge or when returning to the ED for care several days after discharge. It makes sense that failure to recognize clinical warning signs as a potential cardiac underlying problem resulted in a delay in or a lack of appropriate workup or evaluation to establish the diagnosis quickly. Oftentimes, the diagnosis was missed at multiple visits because respiratory signs and symptoms, including that shortness of breath, cough, and tachycardia, were associated with pulmonary issues like pulmonary embolism, asthma, and pneumonia, or anxiety instead of cardiac disease. Anxiety, in fact, was the single most common misdiagnosis when women presented to their physician or the ED with these symptoms. New onset asthma was the second most common misdiagnosis. In other cases, back pain was associated with pyelonephritis, kidney stones or urinary tract infection, and symptoms related to cardiomyopathy were assumed to arise from the woman's substance use rather than indicative of cardiac failure. Next slide. Of the QiOs within the response domain, 3 themes became evident, including delayed treatment, inadequate or inappropriate treatment, and lack of follow-up. Delays in treatment were largely due to a failure to recognize presenting signs and symptoms as a cardiac problem. Missed symptoms and misdiagnosis led to delays in obtaining necessary diagnostic measures such as EKGs, chest x-rays, cardiac enzyme analysis, delays in administration of medications, consultation with MFM or cardiologists, and delays in intubation, initiating a code, advanced cardiac life support resuscitation, and performance of perimortem cesarean. Delays in triage and transport were also indicated as opportunities to improve outcomes. Most triage opportunities included women who reported chest pain, shortness of breath, or neck and back pain. Inadequate or inappropriate treatment was centered in the mismanagement of the woman's deteriorating condition. In the examples of poor management, lack of communication, not following professional standards of care, optimal or suboptimal cardiac evaluation, and lack of coordination of care were among identified areas needing improvement. Some women's conditions were worsened by administering contraindicated medications, such as nifedipine, or administering too much intravenous fluid. In other cases, appropriate medications, such as Lasix, were administered, but in inadequate amounts, or medications that should have been given, such as ACE inhibitors and beta blockers, were not. A lack of follow-up for women with known risk factors or symptoms was an area of concern and noted frequently. No clear plan was evident on the professional expectation of when women should be seen for follow-up post-birth hospitalization discharge. Several cases indicated a lack of follow-up for women presenting with shortness of breath and or hypertension, and especially in women with morbid obesity. Many of the women who had very high BMI reported symptoms to their clinicians. Although these issues occurred along the continuum of care, it appeared to be a more significant issue in postpartum. So early discharge, especially in women with symptoms or risk factors without adequate follow-up, was cited within several QiOs as contributing factors to mortality. Next slide. So in order to improve mortality rates, women with cardiac conditions need to be at a facility prepared to care for their high-risk needs. The decision on where to care for the woman with cardiac disease is based on her level of risk, the potential for decompensation, and the availability of appropriate equipment, specialty physicians, and nurses knowledgeable and skilled in managing pregnancies complicated by complex cardiac issues. Well-defined maternal levels of care provide that guidance in evaluating the adequacy of a facility's available resources, and have been provided by ACOG and SMFM. Clinician education and the use of social services and ongoing case management in cases of cardiac diagnosis or chronic hypertension during pregnancy was also suggested for improving care. In addition, because of the physiological changes occurring during pregnancy that make cardiac diagnosis difficult, assessment of oxygen saturation on initial evaluation of all pregnant women with respiratory complaints or more frequent use of pulse oximetry monitoring, especially those with known risk factors, should be considered. Several opportunities in this study noted that need for pulse oximetry, especially in cases of suspected new onset asthma. I think we go to the next slide, please. Consequently, assessment is essential to identify women at risk for cardiac-related complications. Several QiOs in our study highlighted the importance of preconception care in women with CVD, especially those with additional social issues. Preconception and interconception are ideal times to address known cardiac conditions and formulate a reproductive plan on, involving an obstetrician, internist, and possibly a cardiologist. However, the first presentation of CVD may be during pregnancy or in the postpartum period. Therefore, risk assessment is important in the first prenatal visit for all pregnant women and throughout the pregnancy and postpartum period. The concern that we had with women's knowledge it really highlights the indication as to the importance of prenatal and discharge teaching for risk factors, especially after the delivery, when women may be overwhelmed with the delivery process itself. The education should include risk reduction strategies, presence of symptoms, and when to seek care. Next slide, please. So this is, I'm sorry, I kind of got ahead of myself with the missed risk factors. So this is where the importance is in the risk assessment, both routinely at the first prenatal visit, throughout pregnancy, in the labor and delivery area, and in the postpartum period as well. Frequent reassessment is needed to uncover those trends and identify if the pregnancy is moving the woman to a higher risk group. We noted several opportunities where early assessment of pregnant women complaining of CVD symptoms may have improved the diagnosis and response time, and therefore improved the maternal outcome. The nurse's role in initial assessment of presenting signs and symptoms, vital signs, and communication with the physician of these findings as potentially cardiac-driven can facilitate prompt evaluation and appropriate treatment. Immediate triage and assessment of pregnant women presenting with potential cardiac symptoms is vital. Of the most prevalent themes in this study was the lack of recognition of those warning signs and symptoms of CVD, either during the initial birth hospitalization or in the postpartum period. As pregnancy progresses, normal findings become more exaggerated and require further investigation to differentiate between normal pregnancy and evolving cardiac disease. Healthcare clinicians should have a high index of suspicion when evaluating symptoms to distinguish those that are pregnancy-related versus CVD, especially among women with known risk factors. As was stated earlier, the earlier the assessment and recognition leads to earlier response, as was noted in several QiOs. Next slide. So the timing of treatment is important to begin immediately. Utilizing diagnostic measures sooner and earlier transport to a higher level of care could have addressed the inadequate resources earlier. Standardized policies for evaluation and medication use with CVD, like the standard use of diagnostic measures to aid in the diagnosis and the standard use of medications for treatment, can facilitate the issue of inappropriate and inadequate treatment. Improved communication and collaboration between different units, especially obstetrics and the ED or the ICU, is very important as well. Co-management of these cases brings together the expertise to completely cover each aspect of the pregnant woman's cardiac condition, both her cardiac issue and pregnancy and the effect that each has on each other. Empowering nurses to communicate concerns regarding the patient's status and assessment findings only enhances that coordination of care. Women with symptoms during the postpartum hospital stay should have earlier follow-up once discharged. The QiOs certainly lend support for the recommendation that women with uncontrolled, unexplained adverse symptoms remain hospitalized until further evaluation and closer monitoring can be completed. Next slide. So as was previously discussed, the CVD pregnancy-related mortality rate for African Americans among the California PAMR deaths was nearly 8 times higher than that for our Caucasian women. Unfortunately, our quality improvement opportunities didn't discover any clear answers to why. Although African American women have a higher incidence of risk factors associated with CVD, including hypertension, obesity, and diabetes, the QiOs did show that African American women presenting with concerning signs and symptoms did not receive appropriate evaluation and treatment on a consistent basis. In general, for most of the QiOs, we found that insurance accessibility was a concern for some of the women in our review, which at times resulted in no prenatal care, late entry into prenatal care, or difficulty accessing care at some point during the pregnancy due to a loss in healthcare coverage. Several quality improvement opportunities indicated that the access to healthcare coverage may have affected the continuity of care, which led to the issue of delayed diagnosis and treatment. Clinicians may not have had knowledge regarding a woman's history of cardiac issues, therefore no evaluation or treatment was completed, and pregnant women delayed seeking care despite the presence of symptoms because they lacked that accessibility. Changes in healthcare and coverage of medical conditions may cause delays in referrals for high-risk care required for women with CVD. With the rising rates of morbidity during pregnancy, it is essential that women with pre-existing conditions have continuous healthcare coverage in order to receive specialized care to minimize the adverse effects of CVD, and they should have the reassurance that their care will continue regardless of whether medical complications arise during pregnancy. Continuity of care provides a seamless transition from preconception to pregnancy, encouraging early initiation of and compliance with prenatal care, and allows for timely recognition and treatment of risk factors. Continuous coverage also ensures the availability of appropriate follow-up care during postpartum and interconception, thus minimizing the long-term effects that CVD can have on women's overall health. Disparities in access to quality care and to appropriate treatment for women of color resulting from racism, chronic stress, and the social environment may be reasons for seeing higher rates of CVD among this population. Therefore, it's also important that clinicians provide African American women and women with CVD risk factors attentive, respectable, and culturally appropriate early, adequate prenatal care, screening, and management. Thank you.
Thank you, Dr. Van Otterloo. We now move to the last speaker of the day, Dr. Afshan Hameed.
Thank you so much, Christine, and thank you, Lucy, for setting the stage. for what I'm going to talk about in the next 15 minutes. So we heard about the racial disparities. That's what we are trying to highlight, and we have these persistent gaps in care when we look at African American women compared to white. And that's not new. That we looking at these data up here. If you take all other races, Black women 3 to 4 times higher mortality rate, not only in California but all through the United States. Next slide. In our own data from California, we can see that amongst all pregnancy-related deaths on the left side bar, 4 times more prevalent in African Americans compared to non-African Americans. And if we take cardiovascular deaths, that gap is even wider. We have 7 times higher African American compared to other ethnic groups. Next slide. And likewise, the mortality ratios, these are distributed amongst the Hispanic, non-Hispanic white, others, and non-Hispanic Black. And the mortality ratios, as you can see down here, is 38.9. Again, there's a huge difference amongst the ethnic groups. Next slide. Now, looking at all of the cardiomyopathy, which is in light orange, darker orange, all cardiovascular deaths, and the gray is all other pregnancy-related deaths. As we go from left to right on the slide, the medical, so these are the publicly funded patients, and we look at, and the cardiomyopathy deaths are tend to be higher in lower socioeconomic group. Obese women, in particular BMI over 30, you have a higher cardiomyopathy compared to other cardiovascular and other pregnancy-related deaths. When you look at African Americans, likewise, you can see more cardiomyopathy. Hypertension is about equal amongst the 3 groups. But as you see down here on the right side, the methamphetamine or the drug use is way higher in the cardiomyopathy group compared to the other ones. Next slide. Amongst the cardiomyopathy deaths, 70% are due to peripartum cardiomyopathy. And amongst those peripartum cardiomyopathy, again, African American women comprise a large group. And this is very important because the peripartum cardiomyopathy, as you know, is an entity, is a disease process that occurs towards the end of pregnancy or in the postpartum period. And that is when there's a lot of other barriers, there are confounders, there is inability of these postpartum women to get to healthcare, and that accounts for the late postpartum deaths that we have, that was brought up earlier by Christine. We still have that graph in California, even though we are doing well in the early postpartum deaths within that 42-day period, which is more reflective of all the quality improvement initiatives, particularly the obstetrical hemorrhage, preeclampsia, and so on. But these cardiac deaths are still there, and they are driven by the peripartum cardiomyopathy deaths. Next slide. And this is a very important slide I'd like to point out, and this is where the risk assessment will come in, as we'll talk about later. When we look at all of the cardiovascular related deaths in this bar, you see the 3% on the left side. These are the pre-existing or known cardiovascular disease. The 8% are the ones who were diagnosed, patients who were diagnosed in the prenatal period, 36% at labor and delivery, 34% in postpartum period, and 48% we didn't know that these women had cardiovascular disease until after the autopsy results were back. And this is very important because that not only tells you that we are not picking these in the postpartum period, but also the fact that even though we have a growing population of congenital heart disease and there are women who have ongoing issues with the heart, these are not among the cohort that died because we knew about them, we treated them, we appropriately triaged them, they got care at the place where they needed to be. The ones that we need to worry about from population perspective are the ones in these 34% and the 48% group. These are the ones beyond delivery. And like I alluded to earlier, these late deaths are primarily driven by the cardiomyopathy deaths, which comprises 43% of the late maternal deaths. Next slide. Now that brings up why are we missing them? And we all know that the symptoms of pregnancy or the signs of pregnancy overlap with those of cardiovascular disease. These women who died, they had presented with these symptoms of either shortness of breath, wheezing, palpitations, edema, chest pain, dizziness, or extreme fatigue. They had symptoms, 43% had presented with these symptoms in the prenatal period. 50% of them had any of those symptoms during labor and delivery, and 80% in the postpartum period. They had abnormal physical examination findings. They were hypertensive, 64% with a blood pressure 140/90 or above. Tachycardic, above 120. 60% of these women had a heart rate of 120. They had other findings that were documented, either crackles on the chest exam or on cardiac exam, either a murmur or a rhythm problem, gallop and S3, and oxygen saturations of less than 90% in 40% of these patients. And again, reminding that only 2 of these women who died, they entered pregnancy with a known cardiovascular disease. 98% of the rest of these women, they actually did not know that they had cardiovascular disease. Next slide. And we know that African Americans are at higher risk, and there are various reasons. First of all, they tend to be hypertensive, more prevalent. Hypertension is more prevalent in African American. There is accelerated progression from, if they are pre-hypertensive, they tend to get to hypertension much faster. They overall have higher nocturnal blood pressure, so the overall blood pressure load in African Americans is higher. They tend to have lower socioeconomic status, their poor nutrition, obesity, genetic factors, and environmental factors. There's a host of these factors that exist in African Americans from the patient perspective that may contribute to their higher morbidity and mortality. Next slide. And they have increased burden of cardiovascular, other risk factors other than hypertension. They tend to have diabetes, like we said, obesity, genetic and environmental factors. Next slide. And we heard about it earlier as well. In general, cardiovascular complications are more prevalent. Overall cardiovascular mortality, 3 times higher, and in younger population, less than 50 years of age, 6 to 7 times higher when compared to the white population. Next slide. One thing to remember whenever we are talking about cardiovascular risk factors, identifying these women at risk and triaging them when they come in with symptoms, is that any cardiac disease, any form of cardiovascular disease is going to present either with heart failure or with arrhythmia. And the ultimate downhill spiral will lead to their death if we don't identify them. Next slide. A typical prototype case that we had reviewed many, many times, sadly enough, is a young woman who is obese, African American, presents 10 days after an uncomplicated vaginal delivery with fatigue and persistent cough since delivery. Her blood pressure is relatively normal, but the heart rate is 110. Respiratory rate is a bit on the higher side, 28 per minute, afebrile with oxygen saturations of 94% on room air. She gets diagnosed with respiratory infection, prescribed antibiotics. Fatigue is attributed to lack of sleep by the healthcare provider. Next slide. 1 week later, she presents again with continued symptoms. Antibiotics are now switched. She is given beta agonist with a presumptive new onset asthma diagnosis. 2 days later, the patient experiences cardiac arrest at home and resuscitation attempts are unsuccessful. Autopsy findings are indicative of cardiomyopathy. Next slide. Based on these cases, based on the information that we got from detailed review of medical records, we came up with an algorithm. We divided this into 2 parts. The first part is the red flags, or the personal history of cardiovascular disease. Red flags is when a woman comes in and she's short of breath at rest. She's literally sitting up, can't sleep, can't lie down flat. She's using 4 or more pillows. She's tachycardic to 120 or above, systolic pressure over 160, respiratory rate of 30 or above, O2 saturation is 94% without personal history. And then women who have personal history, any history of cardiovascular disease, those are the 2 groups of women. Those are the highest risk of morbidity and mortality. And the recommendation from these reviews from our multidisciplinary group was that they need prompt evaluation. They need consultations. They need to go into the hospital and evaluate their cardiac status. Next slide. And then the rest of them, women who don't have red flags or personal cardiovascular disease who are otherwise stable, then you have to evaluate them based on their self-reported symptoms, vital signs, their underlying risk factors, and whether they had physical examination findings. And once again, if you have a physical exam finding, they go down the path of further evaluation. Whereas the rest of the 3 components of this algorithm, depending on what symptoms they have and what vital sign abnormalities, if there's 1 symptom, 1 vital sign, and 1 risk factor, combination 3 or more, or any combination leading up to 4 or more, they need to be evaluated further at the minimum EKG, BNP, and further evaluation depending on those results. Next slide. We applied this algorithm to the 64 cardiovascular deaths. 88% of these cases would have been identified, and the detection rate increased to 93% when the comparison was restricted to the 60 cases that were symptomatic. We would have identified them, and as we know, once we identify a woman with cardiovascular disease, they have a much higher chance of getting treated and triaged, and perhaps could have saved a life. Next slide. So the next step for us is to take the information from the toolkit and apply it to our clinical setting. And we started doing that at our own institution a few months ago to get a baseline screening on all pregnant women and pregnant and postpartum women, and to establish the screen positive rate, because the numbers that we got were from the mortality reviews. Now, the goal is to get this implemented real time so that we know what the baseline rate is, and we can validate this CVD algorithm and fine tune it so that this could be a component for all comers, all pregnant and postpartum women. Next slide. We have devised a template into our electronic medical record system, and we screen all women. Where if they are screened positive based on the algorithm, they go further cardiac testing. And I'll encourage all institutions, all places in California and outside of California to collaborate on this, because we have information at our institution on about 350 cases that we did over a 3-month period, and we have a screen positive rate, and we continue to recruit more patients. But our patient population is skewed. We only had 2.5% African Americans in what we have done. So what we need is throughout the country, get this screening implemented and gather information so that we can actually validate and then have a risk assessment tool, which is simple to use to identify these women. Next slide. I'm just going to skim through the next few slides. I'm running out of time. And these basically, I said that already, we applied this algorithm, and we have an abstract that was accepted for a poster presentation at the SMFM coming up in 2019. So we'll share that information with you. Next slide. And the primary outcomes, of course, were the screen positive rate, and the secondary outcomes are what kind of cardiac disease did these women have, and if they needed cardiovascular medications. Next slide. Next slide. And these are just the screenshots for your reference as to how it's built in our EMR. There are drop-down menu for each one of those red flags and personal history, which takes you to screen positive. Next slide. And then a combination of risk factors that gives you the points that the patient screened positive for. Next slide. And once they're screened positive, we put it in their problem list so that what we are trying to do is to have this problem identified or cardiovascular screen linked to that patient record so that we don't screen them again during pregnancy, and also to make sure that we don't miss screening the ones that have not been screened before. Next slide. So I'll stop there, and I let Christine finish off with the great work that has been done so far, and I'd be happy to answer any questions that you may have. You can ask questions on here, or you can also direct questions. I can give you my email, and Christine can share it at the end of the webinar.
Thank you, Dr.
Thank you very much.
Thank you very much. As Dr. Hameed said, we have these toolkits that are available for you to download and look at that address these issues. And we are very excited about the implementation work that Dr. Hameed is currently conducting. Again, I want to leave you with this slide to let you know that maternal mortality can be addressed. We can make a difference. And it's important to use all the tools and resources at our disposal in order to do that. I'm sorry that we did not have time at the end for the Q&A due to the technical difficulties at the beginning. However, you may email me, cmorton@stanford.edu, with follow-up questions or comments, and I will refer them to the panelists if necessary. And we will be sending out an evaluation survey tomorrow by mail. It's really important for us to hear from you, our audience, so that we can continue to bring you webinars that are relevant to your ongoing work to improve maternity care outcomes wherever you are. Thank you so much. If people are willing to stay, however, and if our panelists are willing to stay, I do see questions coming in. The slides will be available by mail, which is one of the questions. Let me see here. Let's answer. There's a question by Kristen Beaver. The BNP results, we wonder why this test isn't used more often. What is the result that is the warning? I'm remembering over 100 being the number to be indicative of CHF or CVD. Afshan, are you able to answer that?
Absolutely, absolutely. I think that is a great question. And BNP, like Kristen brought up, I think this is a very simple test. It should be used more often. That is part of the algorithm. The result that is abnormal is over 100. You are absolutely right. And also remember that even though the pregnancy is considered a state of volume overload, a lot of people think the BNP level is going to be higher, but we did a study where we showed that BNP remains well within normal. It goes double the baseline for women. For example, if it's 10, it'll go up to 20, 25, but well within the normal range. Anytime it's abnormal, the patient needs further workup. Thank you for bringing that question up.
Great, thank you. Here's another question by Faud Atala. What do you mean by some preventability in your assessment? And since you started working on this, have you seen a change in the CVD mortality trend?
Yes, so when we did the mortality reviews, we had 3 categories of preventability. It was a strong, a good to strong, or some or none. This was just to stratify the efforts that could have been done. For example, if this was a patient with a end-stage heart failure, the preventability was not as great as somebody who had a relatively or higher ejection fraction, for example. So they were categorized as some. The sum means that there's, again, some preventability, but not good to strong. But if we combine them together, it becomes more prominent.
We have one last question here from Marie Marsden. I am a 44-year-old African-American woman, and I continue to overcome a peripartum cardiomyopathy diagnosis from over 16 years ago. Through assistance of my LVAD over 6 years ago, I was troubled to learn my current home state, Georgia, leads the nation in maternal mortality. Based on my research, California is leading the way in combating this issue. In what way does California plan on working with other states, and how can I as a patient advocate get involved? Well, I will take a stab at answering that first. Thank you, Marie, for your question. California is in fact leading the way. The medical director of CMQCC is currently the medical director of a national initiative called the Alliance for Innovation in Maternity Care, or AIM. And you can find out more about that program at the safehealthcareforeverywoman.org website. As a patient advocate, you can get involved at the local level. If there is a quality care collaborative in your state, they may include and invite patient voices. And the National Council on Patient Safety and Women's Healthcare, which is the overarching organization that sponsors the national program, they have opportunities for patient representation. And you can go to that website, again, safehealthcareforeverywoman.org, and learn more about that. Oh, and one of our...
Women Heart.
Women Heart is also another place where you can join to become an advocate. I know they offer workshops, et cetera, for women who've had heart disease to become advocates. And another one of our comments says, there is an AIM present in Georgia. I can help her connect with the Georgia members. So thank you. Thank you for all of these questions, and thank you for those of you who've stayed with us to the bitter end. Stay tuned for the evaluation survey in your email tomorrow, and thank you very much for your time. The webinar is over.